Good afternoon. My talk today is on the use of SD-OCT in subretinal pathologies. I'm sorry for the little delay because they had messed up my presentation. It has not come to this itself. This is just to show you the layers. Now, I am going to concentrate, since the other people have sort of outlined the epiretinal and intraretinal. I am going to outline the subretinal pathologies, which involves the neurosensory and sub-RPE. It's a whole big list, as you see here. There's CSR, there's ARMD, PED, IPCV, RPE, RIP, inflammations of different kinds, toxicities, degenerations, dystrophies, tumors, trauma. It is not possible to cover all this in 10 minutes, but I will try to run over fast and show you whatever is feasible. Now, what is the use of OCT? Is it only of supportive value to our other investigations? Or is it a window to suggest or document pathology? Or is it a means of documenting lesions not picked up on fluorescein angiography and ICG? Or is it a convenient tool to follow up post-op treatment? The answer would be yes, all of the above. Thus, it is an invaluable tool in the present day scenario. Now, when we're talking of central serous retinopathy, what do we generally see? We see on the OCT serous retinal detachment with or without PED. The OCT helps us to differentiate CSR from other lesions like macular cyst and others. It also helps to document the improvement of these patients. Sometimes it helps us to detect a CSR where there are no leaks seen on the fluorescein angiography, or detect a PED which is not seen clinically. So it works both ways. Now, when we talk of an idiopathic CSR, this is a patient where you will see that there is a patient with CSR. The patient has a neurosensory elevation with a small underlying PED. And if you see on the spectralis, this is the ISOS junction which is showing irregularity. So the extent of band disruption, which is clearly seen on the newer OCTs, and the presence of subfoveal defects in this correlates with the degree of visual loss which is seen in the patient. Now, this is another patient. The top shows a pure CSR where there's only a serous retinal detachment, and the lower part where it is associated with a pigment epithelial detachment. Obviously, this case, the lower case, would have a little longer period of follow-up and a longer time to settle down. Now, this is sometimes has to be sort of differentiated from what we call as a macular cyst, which appears as a large circumscribed optically clear space with thinned out neurosensory retina. Now, again, this can be differentiated from edema and cyst, which has been sort of clearly spoken to you by Ashish. Then foveal schisis, where it typically shows a kind of peaked elevation of the foveal pit, and there is splitting, perifoveal splitting of the neurosensory retina, which you see over here. This is to show you an enlarged view of the same thing. Now, this is a patient of PED, which he had a 58-year-old male patient whose vision had suddenly dropped to 20 by 200. And if you see that, you could kind of make out that there is a possibility for PED, and there was a hotspot which was seen on the fluorescein angiogram, but nothing else conclusive that whether it is PED associated with which condition. So this was helped with the help of the OCT, because you get a typical picture of a CSR with a PED elevation. Now, the thing is that it helps to document, and the importance is that this patient is a very stressed out patient and he's very apprehensive about how he's going to improve. So on every subsequent visit, when you show him a decreasing level of edema, the patient goes back happier and less stressed. So it doesn't add to his already existent problem. A similar patient, similar case scenario in another patient. Now we come to ARMD. Now, when we're talking of ARMD, we will be talking about drusen, geographic atrophy, hyperpigmentation of the RPUs, serous hemorrhagic PED, and the CNVMs. Now, when we talk of ARMD, it's better to, it helps us to confirm and to stage the ARMD, whether we are talking about a dry or a wet type, and what is the kind of lesion and at what level. It helps as an adjunct to FFA ICG. It helps to differentiate types of PED and CNVM, and also helps to study response to treatment. So, we are going to divide this into 2 or 3 parts where we are going to talk about the categorization of the disease, where I'll run over a few case examples. Then we are going to talk about its association with other pathologies, that is dual pictures in the same patient. And then I'm going to talk about the response to treatment, how it helps and what is the response that we have seen. Now in the non-neovascular PED, let's go over it quickly. This is drusen. It could be soft drusen or it could be sort of hard drusen. And if you see this, the hard drusen, you will get focal elevations where you will be some amount of backshadowing. And in the soft drusen, you will not get this kind of thing. They are just soft elevations seen over here. Whereas in patients who have calcified drusen, you will see a very distinct backshadowing to know which is the kind of drusen we are dealing with. Some of these drusens are also associated with small PEDs. So this is what we call as a drusenoid PED. And then the geographic atrophy, where you see a total thinning of this RPE layer, and you know that the vision is, it can be seen clinically of course, but it also helps to corroborate and show to the patient what the patient has. So this is a small look over of the different types of dry ARMD. And then we come to the neovascular PED, which consists of the classic occult mixed, which was very important in an arena where we were doing the PDT along with the other, either a combination or a single therapy. But the thing is that since there is a changeover to anti-VEGFs and more of use of anti-VEGFs, we generally don't have to categorize these forms, but still it is important to know what we have on hands. So the thing is that if you see a classic CRVM, it appears as a classic fusiform elevation with sort of disturbance in this layer, and this is a classic case where there is no subretinal fluid seen over there. So then you can decide on what treatment you want to do accordingly. And this is an occult CNVM again, which is sort of associated with a PED, and this is on a different form of OCT where the definition is much better of the lesions which are seen in the same patient. Now this is a patient of a mixed CNVM. Again, it helps you know where the thing is, what is the reason of the visual loss, and what kind of treatment you're going to offer. Then let's come to dual pathologies. Now dual pathologies is that, okay, is it as a CNVM alone, or is it associated with some kind of cystoid macular edema in the overlying retina or subretinal fluid? And the cause of visual loss sometimes is more because of the secondary pathology rather than to the CNVM itself. So this is a case with exudation with cystic changes that you see in the overlying retina, and this is another case of fibrovascular PED which you see here. Then CMVM with a CSR. It can be associated with a CSR, where a neurosensory elevation with a CNVM. So you have to modulate your treatment accordingly. This is another patient who had a juxtapapillary CNVM, again seen beautifully, and there is a serous amount of serous fluid present in this area. Then there is association of a CNVM with a overlying cystoid macular edema. Again, it helps you plan your treatment and also the response to treatment thereafter. This is a subepithelial occult CNV which is seen, and this is the RPE elevation which is seen here. Then this is a CNVM where there is no fluid at all. And again, the thing is that you have to know what you're dealing with. CNVM which is not clearly seen on angiography, it's a very diffuse picture, you really don't know whether there's a CNVM, but on the OCT you can clearly make out the area of the CNVM. So this is where the advantage comes in, where you know that there's okay, we need all the modalities, but one modality may help, the other may not. So the thing is, they're all supportive to one another and they are very necessary in today's age. Again, a disciform scar, high hyperreflectivity with a lot of heaping of RPE. This is associated with a CME. So the thing is that here the patient may not have that good a visual function as the previous patient. Means whatever good there is. Now this is another patient. Now when you look at him, okay, he's got a history of trauma. You may suspect it, but you really don't know because it's such a bizarre picture. There is fluid over here, there's blood over here, and there's a whole area of neurosensory elevation. And see what you get. You get a area of double folding of the RPE with a shadowing behind, with sensory serous fluid, with loss of RP in this area. So you know that you're dealing with a RP, and prognostically this this patient would not have a very good prognosis. Then serous PEDs and serous PEDs with CNV. Now come to the next subset, that is IPCV. Generally, by and large, when you see a whole big blood clot in the central macular area, you don't know whether you're dealing with a CNVM or with an IPCV or some other condition. But the thing is that there are procedures which help you. This is documentation of the same patient on the OCT, and this is the same patient where the ICG has been done, and you find these little characteristic spots which give you the diagnosis of an IPCV. Now the thing is that this patient was treated with laser to the spots, and then Avastin was given, and you found a kind of improvement, steady improvement in this patient, and at 6 months the patient has regained a vision of 6/6 from the initial vision, and there is clearly the central macula is absolutely back to normal. Now, this is different things on the spectral OCT where you find on a classical basis how the IPCV would look, or they would appear as mild focal elevations, which is seen with a little PED over here. Now, in traumas again, you know at which layer the effect is there, because if there is bleed over there, you really don't know which layer is getting affected. And on the USG, you can make out an elevation, and this tells you whether there is any underlying pathology other than the serous detachment and the status of the RPE. Now, this is another patient for post-traumatic, this where he had a circular bleed at this with a little organization because it was about a week old, and there was a pigment ring and a little blood. And see what has happened over here. You see that there is a heaping of the pigment, loss of RP, and there's a swaying back of the RP in this region, probably because of the presence of blood. Now, response to treatment is the next category that I'm dealing with. Predominantly classic, if you take this patient, a first patient who has a vision of 20/20, you see a classic lesion over here. 5 weeks after PDT, vision improved to about 20/70, so it helped us document what was the difference, and the patient is happy because there is a vision improvement also along with the modality. But 3 months, the patient again lands up with a recurrence, and later it is injected again, and you find a resolution which you see with fibrosis. There's a little fibrosis, so the vision has come to 20/30. Similar case, SRNVM with a PED after Avastin injection, and you find a resolution at month 2. At month 4, the patient has regressed completely. At month 10, you find again there is a recurrence, so you re-inject, and there's a resolution at 12 months which has maintained. So you have to decide on how many kind of injections you have to give depending on what you find. This is another patient where you have a mixed kind of TMB which is stable after 3 injections, and the OCT thickness decreased from 341 to 195, and then there was a recurrence at the 5th month where there was a drop of more than 5 letters. So you repeat the ranibizumab, and the thickness comes down to 221, and then again a recurrence occurs. Then you do a combination treatment, and finally at the end you get a patient at month 12 with a CMT of 186. Now, this is a patient of VKH. Again, the classically seen lesions is multiple serous detachments which are seen. The vision is down to 20/20. Following steroid therapy, the patient's vision is restored to 20/30. So you can see it classically, the multiple serous detachments and how it has come back. The next patient is that of a sympathetic ophthalmia. Again, a very classic clinical picture. Then you see this thickening on the OCT also, multiple serous detachments seen. This is a 25-year-old male with a globe injury to the right eye, and the left eye had this problem after 10 days. And post-treatment, you find that when prednisolone was given for 3 days, it improved within 1 week with complete resolution of the SRF. But you have to keep a watch on these patients. Then patients of acute multifocal placoid pigment epitheliopathy, again showing improvement after the treatment with steroids. Now, there are certain patients where you operate but you do not get an improvement in vision, and there again the OCT helps you, because see, this is a patient who is buckled but his vision didn't improve. The OCT showed that there was a traction of the vitreous on the foveal area. He went through a vitrectomy, and post-operatively he is doing fine with resolution. Again, this is a post-buccal patient where you find that it doesn't improve too well, and vision is 624. So you do an OCT, you find a small PED, and over a course of 6 months this flattens out. Then the restoration of vision is there to 612. Poor vitrectomy, post-vitrectomy, poor vision, again, area of scarring here, little area of viable things, and when you do the OCT, you find an absolute thinning, so you know that the vision is never going to improve in this patient. Another patient where he has a yellowish lesion here, slightly elevated, not very much so. Again, on the OCT, you get a heaping over here, which tells you that this is a vitelliform dystrophy. This patient was a 3-year-old boy who came with the parents complained that the child was looking down all the time, not looking centrally. Another case of choroidal hemangioma, vision 2200, and the thing is that on the OCT you get these kind of changes, which then regressed after the PDT treatment given to the patient with restoration of vision to 2025. Patient of choroidal nevus, okay, and then at the macula you get a occurrence of a PED. So though the lesion may be somewhere else, the swelling can be at the macula, and this is what we need to document. Retinal dystrophies at different stages, Stargardt's where you get a complete thickening, and sometimes on the new OCTs you can get the visualization of the liposuction in these patients. It also helps to differentiate the X-linked retinoschisis patients. So in conclusion, I would like to say that OCT is a very useful diagnostic tool. It's a non-invasive investigative tool. OCT requires to have relatively clear media, and it is an adjunct to FFA and clinical examination. But many a times it helps detect things which may not be picked up on the FA and ICG. And OCT is an ideal tool for treatment and follow-up. Thank you so much for your patient hearing.
Thank you, Dr. Karobi.